All right, hello students. This is Dr. Jenkins, and in this module we're going to be talking about chest pain. These are the learning objectives for this session. So we're going to be talking about the differential diagnosis for chest pain, pathophysiology of myocardial ischemia, different ways to classify chest pain, and different ways to evaluate and test for ischemic heart disease, as well as treat ischemic heart disease. And we're also going to cover a few specific causes of acute chest pain, including acute coronary syndromes, acute aortic syndromes, and pericarditis. Chest pain is a very common reason people come to the emergency department. It's the second most common behind, I think, accidental trauma. It's important to note, though, that most chest pain in the emergency department is not cardiac. Only 5% of patients in the ER with chest pain are having an acute coronary syndrome. But coronary artery disease is very common, still the leading cause of death in the United States with over 365,000 deaths annually. And chest pain is the most common symptom of coronary artery disease. So anytime you're seeing a patient with chest pain, you have to be thinking about the heart, even though it's usually not going to be the heart. So here's your differential diagnosis, looking at life-threatening causes of chest pain like acute coronary syndromes, aortic dissection, PE, etc., and then also thinking about common causes of chest pain, which maybe aren't life-threatening, but can still be pretty debilitating. Now, the first thing that you want to know about a patient with chest pain is whether that chest pain is acute or chronic. If they have acute chest pain, then you really need to be thinking about those life-threatening emergencies and evaluating for those. If it's chronic chest pain, then really the first steps are trying to figure out, is this cardiac chest pain or not? So, stable angina is chest pain caused by coronary artery disease. It's typically described as retrosternal discomfort, and people will use other words to describe the pain like pressure, tightness, squeezing, or heaviness. The classic thing is people say that it feels like someone's sitting on their chest or an elephant sitting on their chest. But they may just have dyspnea, which should be considered an anginal equivalent. And the pain can be difficult to localize because it is a deep visceral pain. It may radiate to the shoulders, the arms, neck, jaw, back, and abdomen. Now, classically, angina is provoked by exertion or emotion, and it's going to build in intensity over minutes. And it will resolve with rest or if you give nitroglycerin, and that resolution is also usually gradual. Patients with stable angina will often have other symptoms like nausea or diaphoresis. And stable angina is caused by myocardial ischemia. And myocardial ischemia is the result of an imbalance between oxygen supply and oxygen demand. So myocardial oxygen supply is determined by oxygen content and coronary blood flow, and demand is determined by wall stress, heart rate, and contractility. So let's talk a little bit more about that. All right, let's talk about coronary blood flow. So the heart is very efficient at extracting oxygen from its blood supply. And so the main way you're going to increase oxygen delivery to the myocardium is by increasing blood flow. And blood flow is determined by Ohm's law, where flow is equal to the change in pressure over resistance. And so one of the best ways to increase blood flow is by decreasing resistance. And resistance is determined by Poiseuille's law, right? So resistance is equal to 8 times the viscosity of blood times the length of the vessel divided by pi times radius to the 4th power. So resistance is inversely proportional to the radius of the vessel to the 4th power. So small changes in radius are going to have big changes in resistance and blood flow. Coronary artery disease is caused by atherosclerosis, and atherosclerosis starts with activation of endothelial cells. The main things that activate endothelial cells are high blood pressure, turbulent blood flow, lipid products, diabetes with advanced glycation end products, cigarette smoke, and other inflammatory processes. And once these endothelial cells are activated, you're going to get accumulation of lipoproteins like LDL in the vessel wall. You get migration of macrophages into the intima and adhesion of platelets. And these activated macrophages and platelets are going to recruit smooth muscle cells, which are going to proliferate and lay down extracellular matrix, which makes the intima thicker. And you also get this calcified necrotic debris. Atherosclerosis progresses from a fatty streak to intimal thickening and eventual plaque expansion. But not all plaques are the same. Some plaques have a very thin fibrous cap and a large necrotic lipid core, and those plaques are more likely to rupture, leading to acute coronary syndromes and sudden cardiac death. But other plaques have a thicker fibrous cap with more collagen and extracellular matrix, which makes them more stable, but they will still decrease the radius of the lumen, leading to higher resistance and lower blood flow. And once there is critical stenosis, usually more than 70%, you're going to have insufficient blood flow, and that results in anginal symptoms. So we've talked about the blood flow side of the equation. Now let's talk more about the demand side. The myocardial oxygen consumption is determined by three main factors: heart rate, contractility, and wall stress. So heart rate makes sense. If your heart is beating faster, you're going to need more oxygen. Likewise, if your heart is beating more forcefully, you're going to need more oxygen. And then the last thing is, if you increase wall stress, you're going to consume more oxygen as well. And wall stress is determined by Laplace's law, where wall stress is directly proportional to the pressure inside a vessel times the radius of that vessel divided by 2 times the thickness of the vessel. So when we're talking about wall stress of the heart, we're usually talking about the left ventricle. And so if you have increased pressure on that left ventricle because you have an increase in afterload, say you have really high blood pressure, or you have aortic valve stenosis, and that left ventricle has to contract against higher afterload or higher pressures, that's going to increase wall stress. Likewise, if you increase venous return and preload to the left ventricle, and you stretch that ventricle and you increase the radius, that's also going to increase wall stress. And both of those things are going to increase myocardial oxygen consumption, increased afterload, and increased preload. So if you think a patient has stable angina, the first thing you want to do is estimate the pretest probability of them having coronary artery disease. And we usually divide that up into low risk, which is about 15%, intermediate risk, which is a really wide range, 15 to 85%, and high risk, 85%. And so where do those numbers come from? This comes from the Diamond and Forrester classification, which is pretty old now, 1979, kind of a different era. But they broke people up into 3 categories. They said if you had typical angina, which was substernal discomfort provoked by exertion, relieved by rest, then they called that high risk. You had an 85% pretest probability of having coronary artery disease. If you only have 2 out of the 3 characteristics, they called that atypical angina, and that put you in this intermediate risk of 15 to 85%. And if you had 0 or 1 out of 3 characteristics, they called that non-anginal chest pain, and that was low risk, 15% or less pretest probability. And so this is from their original paper in 1979, showing kind of how they derived these numbers. But in patients who had typical angina in their study, 89% of them had coronary artery disease on an angiography, versus if they had non-anginal chest pain, only 16% had coronary artery disease on angiography. If they had atypical angina, it was about 50%. Now, while the Diamond-Forrester classification might have been accurate in the 1970s, in more recent studies, this classification scheme overestimates risk. So in a more recent study, the PROMISE trial, when they looked at prevalence of coronary artery disease in people based on these classifications, if the predicted prevalence was 40%, they really only saw it in about 14% of patients. There are newer models for estimating pretest probability in the modern era, and so those are going to use age, sex, and the symptoms, and you can also use like a coronary artery calcium score, which is a special CT scan that looks at how much calcium is in your vessels. Okay, this is kind of a busy diagram, but basically if you have someone with stable chest pain with no known prior coronary artery disease, the first thing is that clinical risk assessment where you try to decide, is this person a low risk person, like based on their symptoms, their age, their sex, I think they're low risk, or are they intermediate risk? And if they're low risk, on this algorithm, no further testing would be recommended. If they're intermediate or high risk, that's when you're going to start looking at different stress tests and anatomical testing. So in low-risk patients with stable chest pain, if they have a pretest probability that's less than 15% based on their age, sex, and symptoms, they do not require further testing like a stress test. The guidelines do say you can do coronary artery calcium testing. If they have a score of 0, then their prevalence of obstructive coronary disease is less than 5%. The guidelines also say that you can do exercise, EKG, stress test, but that test is not going to change your post-test probability if you have a low pretest probability, but it can assess their functional capacity. If they can run on a treadmill, that may be good to know, but it's not going to change your post-test probability of whether they have coronary artery disease. So for your intermediate and high-risk patients, you're going to want to do further testing to evaluate whether they have coronary artery disease. And there's a few different options. You can do anatomic testing, which includes CT coronary angiography and invasive coronary angiography, or you can do stress testing where you actually stress the heart to see if there's any evidence of ischemia. And so there's a lot of different options for stress tests. You can do the exercise EKG stress test where you put them on a treadmill with a bunch of EKG leads and you make them run. And you see if there's any changes in the EKG pattern like ST depressions or other signs of ischemia. You can do stress echocardiography where you also could make them run on a treadmill, or you could give them a medication like dobutamine to increase heart rate and contractility, and then you look for any changes like in wall motion that would suggest ischemia. Then there's these fancy nuclear studies like PET scans and SPECT that you can do, or you can also do stress MRIs. CT coronary angiography is a really useful tool because you can actually visualize and diagnose obstructive and non-obstructive coronary artery disease, and it's not invasive. And this has some advantages over like a stress test because you can actually detect non-obstructive coronary disease as well. Maybe they're not actually having ischemia, but they do have non-obstructive coronary disease. You're going to pick that up on a CT coronary scan. One issue with this test is that the heart rate does need to be less than 60 typically for it to be accurate. And so, if the patient has an arrhythmia like atrial fibrillation or sinus tachycardia, then they may require a beta blocker before they can do this study. And the study uses contrast dye. And so if the patient has like an iodine allergy, then they may not be able to do this. Invasive coronary angiography is your gold standard, and this is going to allow you to very accurately define the amount of obstruction, the severity of obstruction, and how big the lesions are, and also determine whether these are lesions that are intervenable. Could you put a stent in there, or do they need bypass surgery? And really, this invasive coronary angiography should only be used in patients who have a positive stress test or a positive CT coronary angiography. So the question comes up, should we do CT coronary angiography on these patients or should we do a stress test? And there was actually a randomized trial that looked at this, published in 2015, called the PROMISE trial. They had 10,000 patients with suspected coronary artery disease that they randomized to either CT coronary angiography or stress test. And the stress test group, most of them had a nuclear stress study, but 22% had a stress echo, 10% had stress EKG. And the study found no difference in their primary composite outcome, which included death, MI, hospitalization for unstable angina, or procedural complications. And so based on that study, I think the guidelines say either approach is appropriate if you want to start with a CT coronary or if you want to do a stress test. Interestingly, if you had a negative test with the CT coronary, your risk of coronary artery disease over 3 years was very low, 0.9%, versus 2% for stress testing, which is also pretty low. All right, let's talk about treatment of chronic coronary disease. So obviously we want to target the underlying atherosclerosis. We also want to treat the symptoms, so we need to increase blood flow and oxygen supply, and we need to decrease myocardial oxygen demand. Now, the guidelines refer to treatment as optimal medical treatment, or OMT, and the first pillar of that is going to be diet. And so one of the diets that's been studied the most in cardiovascular disease is the Mediterranean diet, which in some studies has shown a reduction in cardiovascular death up to 65%. This diet is plant-based, lots of legumes and nuts, lean proteins, complex carbohydrates, olive oil, fish, those types of things. You want to avoid too much saturated fat, sodium, processed foods, refined carbohydrates, basically the American diet, and avoid like trans fat. We know that cigarette smoke is one of the worst risk factors for coronary artery disease and atherosclerosis, and smoking cessation has a huge effect in cardiovascular disease reduction. And so every patient who is using tobacco should be counseled on cessation and be offered assistance with nicotine and varenicline and all of those things. Previous studies seem to show that some alcohol use might be protective for cardiovascular disease. Those studies were probably confounded by lifestyle and socio-demographic factors. There's no randomized trials that support alcohol consumption to reduce cardiovascular disease risk. And so it's important to just counsel patients on what an appropriate amount of alcohol is, because excessive alcohol use is associated with higher cardiovascular risk and acute myocardial infarction. High-intensity statins are recommended for everybody with coronary artery disease, and your goal is to reduce LDL by at least 50%. So your high-intensity statin options are atorvastatin and rosuvastatin, and if patients are unable to tolerate high-intensity statin, then you can do a moderate intensity, but your goal is to have them tolerate the highest dose possible. If patients are high risk and their LDL remains over 70, the guidelines do recommend adding ezetimibe, which is a pretty cheap drug, to further lower their LDL. If they're very high risk and their LDL is over 70 despite high-intensity statin and ezetimibe, that's when you could look at adding a PCSK9 monoclonal antibody, which is a pretty expensive treatment. Used to be like $15,000 a year, now it's down to $6,000 a year. That is supported by the guidelines as well. We know that hypertension is a huge risk factor for atherosclerosis and cardiovascular disease, and so we want to control blood pressures. The target is less than 130 over 80, and you can use whatever blood pressure medications you want, but ACE inhibitors, angiotensin receptor blockers, and beta blockers are your first-line hypertension agents for coronary artery disease. And if they're on those medications and they still have high blood pressure, then you can add things like thiazide diuretics, calcium channel blockers, and spironolactone. Cardiovascular disease is the leading cause of death in patients with diabetes. So in patients with diabetes, you really want to make sure you're doing a good job with glucose control. Your target A1C should be less than 7% for most patients. And GLP-1 agonists and SGLT2 inhibitors have been found to reduce the risk of major cardiovascular events. And so those are probably your top options for folks with diabetes and coronary artery disease. SGLT2 inhibitors are especially great if the patients have a reduced ejection fraction or if they have HFpEF. And then semaglutide, liraglutide, your GLP-1 agonists are especially useful in patients who have obesity. The next part of optimal medical treatment is antiplatelet therapy. So low-dose aspirin has been found to reduce the risk of cardiovascular events. If patients have an allergy to aspirin, then they can take clopidogrel. In patients who are already on oral anticoagulation for something like atrial fibrillation, then you should not put them on aspirin in addition to their anticoagulation because the bleeding risk is too high. And then people that are taking aspirin should generally avoid NSAIDs because of the increased risk of bleeding. Okay, our next medication for optimal medical treatment are beta blockers. So beta blockers decrease myocardial oxygen demand by slowing the heart rate and reducing contractility, so they're very effective for treating angina. In patients that have coronary artery disease and an ejection fraction less than 40%, they have been found to reduce risk of death. And so your best options for those patients would be metoprolol succinate, which is the long-acting metoprolol, carvedilol, and bisoprolol. Those have all been shown in clinical trials to reduce the risk of death if your EF is less than 40%. If the patients have never had an MI before, or their EF is over 50%, there's really no benefit to starting beta blockers for coronary artery disease unless there's another indication like they have angina or an arrhythmia. All right, next we'll talk about your angina medications. So we've already talked about beta blockers. The other option would be calcium channel blockers like your non-dihydropyridines, verapamil, and diltiazem. They're going to work just like beta blockers by decreasing heart rate, decreasing contractility, and that's going to reduce your myocardial oxygen consumption. Your dihydropyridines like amlodipine and nifedipine are vasodilators, so they decrease afterload, and that lowers your LV wall stress. And we also have our nitrates, long-acting nitrates like isosorbide, mononitrate, and dinitrate, and your shorter-acting nitroglycerin. These are venodilators and vasodilators, so they're going to decrease preload by dilating veins, and they're going to decrease afterload by dilating arterioles, and that's going to reduce your LV wall stress, and that lowers your myocardial oxygen consumption. And then there's also a medication called ranolazine, which is a sodium channel inhibitor. Nobody really knows how it treats angina, but it does work, and the guidelines recommend it in patients who have tried other multiple therapies and are still having refractory angina. So we've talked about medications to treat coronary artery disease. Now let's talk about who needs revascularization. And revascularization includes percutaneous coronary interventions with balloon angioplasty and stents, and it includes coronary artery bypass grafting. Now you can imagine with the advent of percutaneous coronary intervention, everyone was really excited about putting stents in everybody that had coronary artery disease, right? Because if you're a plumber, you want to unclog the pipes. And so people went kind of nuts with stenting everyone with coronary artery disease. And so when they actually looked at this, though, in a randomized trial, and the first one here was published in 2007, this is the COURAGE trial, it had kind of a surprising result. So they were looking at medical therapy versus PCI in patients with stable coronary disease. They had 2,287 patients that they randomized. You had to have coronary artery stenosis of at least 70% on angiography, and you had to have evidence of ischemia on a stress test. And they were randomized to either PCI plus medical therapy or medical therapy alone. And everyone was surprised to find that there was no difference in the primary outcome of death and non-fatal MI and no difference in myocardial infarction. Here are some of the curves from that trial, and you can see there really is no difference between medical therapy and percutaneous coronary intervention. So since the COURAGE trial, there's been a series of other randomized trials that continue to look at this question of whether PCI adds benefit to medical therapy. And the most recent big trial was the ischemia trial published in 2020. And the ischemia trial was pretty big, 5,179 patients with stable coronary disease with positive stress tests, but they hadn't had an angiogram yet. They did do a CT coronary angiogram on everyone so that they could exclude patients who had non-obstructive coronary disease or if they had left main disease, because those patients benefit from revascularization. They randomized patients to either an invasive strategy where they got coronary angiography and a PCI, or a conservative strategy where they got medical therapy alone with angiography if medical therapy failed. And they had no difference in their primary outcome, which was a composite of cardiovascular death, MI, hospitalization for unstable angina or heart failure, or resuscitated cardiac arrest. So a pretty big composite outcome, but there was no difference in either arm. And there was no difference in their secondary outcome either of death from cardiovascular cause or myocardial infarction. So here are the Kaplan-Meier curves for that study, and you can see that they're kind of interesting. If you look at primary composite outcome, the blue line is the conservative strategy, red line is the invasive strategy, and you actually see at the beginning that there's a higher rate of the primary composite outcome in the invasive strategy, and then eventually the curves actually cross, and then you see a lower rate of the primary composite outcome in the invasive strategy. Now, that wasn't statistically significant, but if you look at the other curves, you can see, especially in box D, that this interesting pattern of the lines crossing is really driven by increased rates of myocardial infarction in the group who got the invasive strategy, and that was mostly procedural myocardial infarction. So you can imagine if you're going in and putting stents in occasionally, you're going to cause some injury to the myocardium, and that's going to manifest as an elevated troponin, which was part of their definition of a myocardial infarction for the trial. But if you look at box C, which was death from any cause, and really mortality is that hard outcome that we really care about, there was no difference. Those lines are right on top of each other. Now, in a follow-up analysis of the ischemia trial, they did find that patients randomized to the invasive arm reported better anginal control compared to the conservative arm. So they used something called the Seattle Angina Questionnaire, and then the summary score was significantly higher in people with the invasive arm compared to conservative arm. When I look at this graph here, I can't really tell a difference, but the statistics said that they were separate. And really, when you see a big difference is when you look at their baseline angina. So if you had a baseline low angina score, which means you have worse angina, they had more benefit from getting a PCI. And so the conclusion from this analysis and what's basically in the guidelines now is that PCI does not improve mortality, but it does improve angina. So why doesn't PCI reduce myocardial infarctions? I think it comes back to the fact that not all plaques are equal, right? So we talked about how some plaques have a thin fibrous cap and a thicker lipid core, and those plaques are more likely to rupture and cause a thrombosis and myocardial infarction. Whereas some plaques have a thicker fibrous cap with more collagen and extracellular matrix. Those are more stable plaques. They are less likely to rupture and cause an MI. And when the cardiologist is doing angiography, they can't really tell what kind of plaque they're dealing with. All they see is that stenosis, right? And so if you put a stent in a stable plaque, maybe you didn't change that patient's outcome. You improved the blood flow there, and so maybe you fixed their angina, but you didn't actually prevent that plaque from rupturing because it was never going to rupture in the first place. So then with revascularization, randomized trials have not found a survival benefit for PCI in patients with stable angina, but it does seem to improve symptoms and quality of life. So in patients who have severe life-limiting angina despite optimal medical therapy, PCI or revascularization is recommended to improve symptoms. If patients have left main disease, which is more than 50% stenosis in the left main artery, or multivessel disease plus LV dysfunction, which is defined as an EF less than 35%, then the guidelines recommend CABG plus medical therapy. That has been shown to be superior to medical therapy alone for improving survival. In patients who have diabetes and multivessel disease involving the LAD, the guidelines recommend CABG over PCI to revascularize those patients. But you can use PCI instead of CABG in patients who are poor surgical candidates. So if you have a patient you don't think would do well with open heart surgery, then PCI may be a good option for them still. All right, so here's our summary then of stable ischemic heart disease. You want to estimate their pretest probability based on their symptoms, age, and risk factors. You're going to do either a CT coronary angiography or stress test for people who are intermediate to high risk. And then if they are positive for those tests, we're going to start them on optimal medical therapy with lifestyle modifications, high-intensity statins, antiplatelet therapies, blood pressure control, and antianginal medications. Patients who have refractory angina or high-risk features should get invasive angiography. And then we're going to do CABG for patients with severe left main disease, multivessel disease with LV dysfunction, and patients with diabetes. Okay, now we're going to switch gears and talk about acute chest pain. So you'll see on this algorithm here that the first step then, if they do have acute chest pain, is get your history and physical exam. And that is going to be guided in part by your differential diagnosis. So thinking about what are our life-threatening and common disorders that cause acute chest pain, that should guide your history and exam. And so we're going to talk about acute coronary syndrome, aortic dissection, and pericarditis, but here are some other causes of acute chest pain that you should not forget about. So once you've gotten your history and physical, you want to get an EKG as quick as possible, and a lot of times that's happening at the same time you're doing your history and physical. The guidelines recommend that you get that EKG done within 10 minutes if you suspect an acute coronary syndrome. And the goal there is to triage patients who have ST elevations for urgent percutaneous coronary intervention. You're also going to look for other signs of ischemia, though, like ST depressions and T-wave inversions, and you may look for signs of right heart strain, like S1Q3T3 or a new right bundle branch block that could be suggestive of other causes of chest pain, like a pulmonary embolism. And in patients who have a high clinical suspicion for acute coronary syndrome, but their EKG doesn't show anything, you should do serial EKGs. Another important diagnostic test that you should do in all of your patients with acute chest pain is a chest x-ray. It's very easy, fast, fairly inexpensive, and you can rule out a lot of causes of chest pain, right? So you're looking for pneumonia, you're looking for a pneumothorax or a pleural effusion. You're looking for other things too, though, like signs of heart failure, like a large heart or pulmonary congestion, and then maybe looking for that widened mediastinum that you might see with aortic dissection. So of our acute causes of chest pain, let's talk about acute coronary syndrome first. This is divided up into ST elevation myocardial infarction and your non-ST elevation acute coronary syndromes. Your STEMIs are going to account for about 30% of ACS, and your non-ST elevation ACS is about 70%. That's mostly going to be non-ST elevation MI or NSTEMI, but some unstable angina as well. So as far as the pathogenesis of acute coronary syndrome, it's usually caused by a rupture of one of these lipid-laden plaques. That's about 60% of the cases. You can also have erosions of a plaque, which triggers a platelet-rich thrombosis in the coronary artery. That's about 25% of cases. If you get a complete occlusion of the artery, you're usually going to get transmural ischemia, which causes ST elevations on the EKG. Now, these ST elevations are the most common manifestation, but they're not perfect for picking up all complete occlusions, so some people will criticize this dichotomous approach. Incomplete occlusions are going to result in subendocardial ischemia, and so that may result in ST depressions in about 30% of cases or T-wave inversions, but you may also not see anything. Acute coronary syndrome can also be caused by coronary vasospasms, spontaneous dissections, and thromboembolism, but those are much less common. So here's just a diagram reminding you that when you have an acute total occlusion of one of these coronary arteries, you're going to get transmural infarction, versus if you have a partial occlusion, you're still going to have ischemia, and that can lead to subendocardial infarction, but it's not going to be full thickness. So here's an EKG showing some subtle ST elevations in lead 1, AVL, V1 through V6. Really, we're seeing them all over the place here. This would be from like a massive left anterior descending artery myocardial infarction. This EKG shows some ST elevations in 2, 3, and AVF. They have that nice tombstone morphology. And just a reminder that you can use ST elevations to localize where the most likely vascular distribution is, right? So in this EKG here, we have ST elevations in 2, 3, and AVF. So you're thinking likely this is an inferior myocardial infarction. The inferior left ventricle is supplied by the posterior descending artery, which is usually a branch of the right coronary artery. It can sometimes come off the left circumflex though too, but typically these 2, 3 AVFs are going to be right coronary. Leads 1, AVL, V5, V6 are typically going to be from the left circumflex, and leads V1 through V4 are more specific to the left anterior descending artery that feeds the anterior left ventricle. Important to remember that ST depressions do not localize to a vascular distribution. It's really just your ST elevations. Cardiac troponin is the preferred biomarker to detect myocardial injury. So if you have a cardiac troponin that's more than the 99th percentile of the upper reference limit, that does suggest myocardial injury. If you check a troponin in a patient with suspected ACS and it's normal, you should repeat a high sensitivity troponin in 1 to 3 hours. And if the patient has 2 negative high sensitivity troponins over 1 to 3 hours, then they have a very low likelihood of ACS and major cardiovascular events. So those patients you can discharge from the ER without further urgent workup. Now, it's important to remember that myocardial injury does not equal myocardial infarction. So anything that causes a myocardial injury can increase your troponin. And so there's a lot of non-cardiac causes or non-acute coronary syndrome causes of elevated troponin, like pulmonary embolism, right? It's going to cause acute right heart strain. That can cause some increased demand. So you might see troponin go up there. Myopericarditis, where there's like actual injury to the myocardium and inflammation of the pericardium, your troponin can go up. Congestive heart failure can cause left ventricular stretch and increased wall stress, so that could increase your troponin. And then other things like hypoxemia, like a patient with pneumonia, their oxygen saturation's in the 60s, they're not going to get oxygen to their myocardium, so they're going to have myocardial injury. That could manifest as an elevated troponin. You also see that in entities like sepsis and shock. So if you have a patient with ST elevation MI, the goal is for them to get a percutaneous coronary intervention within 90 minutes of first medical contact. And if PCI is not available within 2 hours, then fibrinolytic therapy like alteplase and tenecteplase is recommended if the patient doesn't have contraindications. And if you're going to give fibrinolytics, the goal is to give those within 30 minutes of hospital arrival. And then after you've given fibrinolytics, you ship that patient to a hospital that does have angiography because they may still require PCI. The treatment for end-STEMI and unstable angina is a little bit different. You're going to focus on medical treatment first, and there's no role for fibrinolytics. You should never be giving thrombolysis to patients with an end-STEMI because the risk of bleeding far outweighs any benefit. An early invasive therapy within 24 to 48 hours has been found to be associated with lower mortality in patients with end-STEMI, so you still want to get them to the cath lab probably before they discharge from the hospital. But you don't need to do it within the first 90 minutes for end-STEMI. In patients with end-STEMI who do end up getting angiography, about 60% end up getting a PCI, 10% end up getting CABG, probably because they have more diffuse disease, and 30% receive medical treatment alone. So, what is the medical therapy for acute coronary syndrome? This is going to be the same whether it's an end-STEMI or a STEMI. Everyone needs antiplatelet therapy, so you're going to give them aspirin 325 and have them chew it, and they're going to be taking 81 milligrams every day for the rest of their life. P2Y12 inhibitors like clopidogrel, prasugrel, or ticagrelor are also recommended. Prasugrel has been found to be superior to clopidogrel, but it has a higher bleeding risk, and you don't want to use it in patients who've had a stroke. If patients do get a stent, a drug-eluting stent, they're going to need dual antiplatelet therapy, usually for 12 months. And so you want to make sure your patient is actually able to do that before you put a stent in them. Patients also need anticoagulation, usually with unfractionated heparin or low molecular weight heparin like enoxaparin, and that's typically continued until they get PCI. And then all patients need a high-intensity statin. Typically, patients are also going to receive beta blockers acutely for angina and to control heart rate and blood pressure. If they are found to have an EF less than 40%, they definitely need to go home on a beta blocker as well. And then ACE inhibitors, angiotensin receptor blockers are indicated if the patient has an EF less than 40% or if they have diabetes or chronic kidney disease. There's a lot of potential complications of acute coronary syndrome. They may show up in cardiogenic shock, which may require mechanical support and urgent surgery. They might have arrhythmias, LV aneurysm with thrombus, pericarditis, and wall ruptures are also potential complications. All right, let's switch gears now and talk about another cause of acute chest pain, aortic dissection. Much less common than acute coronary syndrome, but can be pretty catastrophic when it happens, so it's important to identify. Most common in patients aged 50 to 70 and more common in males. The biggest risk factors for aortic dissection are hypertension, connective tissue disorders like Marfan syndrome and Ehlers-Danlos, and bicuspid aortic valve, aortic aneurysms, and cocaine use. So there's a lot of potential causes of aortic dissection. So we talked about, there's some genetic syndromes that typically involve abnormal collagen synthesis or abnormal TGF-beta signaling, mutations in protein fibrillin, which is involved in sequestering TGF-beta. But the most common thing is going to be hypertension and atherosclerosis. Hypertension leads to ischemia of the inner media, and you lose smooth muscle cells, and you get abnormal synthesis of extracellular matrix in the media. And then also other things like inflammation, like vasculitis, autoimmune diseases, or infections. You end up with a lot of inflammatory cells and proteases that can degrade the extracellular matrix and elastic fibers of the media. All of these processes lead to the same pathologic finding called cystic medial degeneration. So this cross-section here is from aorta of someone with Marfan syndrome, and what you see is instead of the nice parallel layers of elastic fiber, you see a lot of loss of elastic fibers and fragmentation and patchy areas where there is no elastic fibers. And that's characteristic of cystic medial degeneration. So typically in aortic dissection, you'll get a tear in the intima, usually at the site of medial degeneration, and then blood will enter that defect and tunnel through the media into the different lamellar planes of the media or between the media and the adventitia, and it will create a false lumen, and that can then extend retrograde toward the heart or antegrade all the way down to the iliac and femoral arteries, and in worst case can actually rupture through the adventitia. This illustration shows kind of different ways that this can happen. The classic aortic dissection on the left, happens when there's a tear in the intima. Blood penetrates the aortic media and pushes this dissection flap into the middle of the aorta. And so then you end up with two lumens, a true lumen and a false lumen. The middle one, intramural hematoma, is when blood leaks into the aortic media at lower pressure and forms a thrombus. It doesn't really affect the lumen itself. It kind of pushes the wall of the aorta outward. And then on the right, we have a penetrating atherosclerotic ulcer. And this usually happens in an area of atherosclerosis. You get erosion and blood can penetrate into that, but typically it doesn't dissect or spread very far from the area because there's so much calcification. So you might just end up with a local pseudoaneurysm there. There's a couple different ways that aortic dissections are classified. There's the DeBakey classification, which is based on the origin of the intimal tear and the extent of the dissection. The one that you should know is the Stanford classification, which divides them into two categories depending on whether the ascending aorta is involved. So the type A aortic dissections do involve the ascending aorta, type B do not, and that helps determine the treatment. Patients with aortic dissection come in with very severe chest pain usually. They might describe it as ripping or tearing, but more commonly they'll say it's sharp or stabbing, and it frequently radiates to the back. Physical exam may show a difference in blood pressures, so you want to check blood pressure in both arms and lower extremities to see if there's a blood pressure differential. And then listen for any signs of potential aortic regurgitation on cardiac exam, and look for signs of malperfusion that might be related to the dissection. So a lot of potential complications with aortic dissection. If it ruptures into the thorax or abdomen, those patients often go into hemorrhagic shock. If it ruptures into the pericardial sac, they can develop cardiac tamponade. If it extends into the aortic root, they could develop severe aortic regurgitation with acute heart failure. If it extends into the coronary arteries, they may develop a STEMI. And then if it extends into the renal, mesenteric, or iliac arteries, you end up with organ and limb ischemia. And it can also extend into spinal arteries and cause transverse myelitis. So for diagnosis, chest x-ray may show mediastinal widening, but it's not a very sensitive study for aortic dissection. So if you suspect dissection, you really need to get CT angiography of the chest, abdomen, and pelvis. So you'll see on the CT scan on the right that the aorta has this nice dissection flap separating the two lumens, false and true lumen there. If you can't get a CT scan, maybe the patient's not stable enough to go to the scanner, or they have like a contrast allergy, you could do transesophageal echo or MRI. So management of aortic dissection, your initial goal is to reduce aortic wall stress. So that comes back to Laplace's law. You want to reduce pressure and radius, right? And so patients who have high blood pressure, you want to bring them down to less than 120. If their heart rate's too fast, you want to bring that down as well. And so typically the medications that are preferred would be IV beta blockers like esmolol. If you can't give them a beta blocker because they have a contraindication, then you could use IV non-dihydropyridine calcium channel blockers like diltiazem. You can also use intravenous vasodilators like nicardipine, but you always want to use those with a beta blocker so that you don't get reflex tachycardia, which can actually worsen the dissection. So type A aortic dissections, which involve the ascending aorta, do require emergent surgery. Type B aortic dissections often will just be managed with medications, but some patients may require surgery, and typically that will be done with endovascular stent grafting. Okay, last, let's talk about pericarditis. This is another common cause of chest pain in the emergency department. About 5% of non-ischemic chest pain is from pericarditis. So there's a lot of different causes of pericarditis. The most common cause is viral or also idiopathic, but you have to consider other infections too, especially depending on patients' risk factors. It could be from tuberculosis, which is a lot more common in like Africa. It can also be related to autoimmune diseases like lupus or like a post-MI Dressler syndrome or medications. And then the other things you think about would be kidney failure like uremia, cancer, and radiation therapy. So typically the pericardial space only has about 50 milliliters of serous fluid. But if you have an injury, either from like a viral infection or you just had cardiac surgery, you get an increase in vascular permeability of the pericardium and you get fluid exudation and mesothelial cell desquamation with formation of granulation tissue and fibroblast proliferation. Patients with pericarditis often have a sharp pleuritic chest pain. 90% of patients will say it's worse when they are supine, and it gets better when they lean forward. They may have a low-grade fever. On physical exam, the main finding would be a pericardial friction rub, which is usually high-pitched and triphasic, and it can be heard best with the patient leaning forward, but it may be transient. For diagnosis of pericarditis, you might see signs of inflammation like an elevated white count, an elevated CRP. If they have an elevated cardiac troponin, that suggests that they have a myopericarditis where the myocardium is involved as well. On EKG, the classic finding is diffuse ST elevations with PR depression. And on echocardiography, you might see a thickened pericardium with some effusion, but it could also look normal. So here's an EKG with the classic ST elevations in most of the leads that doesn't follow like a vascular distribution, and that would be suggestive of pericarditis. And here's an image from an echocardiogram that shows the pericardial effusion that can develop in pericarditis. So some of the complications of pericarditis, you could get an effusion that is significant enough to cause tamponade. A lot of patients will have recurrent pericarditis after treatment, and some patients never get resolution of their pericarditis despite treatment. We call that incessant pericarditis. And then a very small percentage of patients will develop constrictive pericarditis, which is more common if they have incessant pericarditis. If pericardial effusions develop rapidly, there may not be enough time for pericardial compliance to go up, and so that can impair your diastolic filling and cause a reduction in stroke volume. So with cardiac tamponade, the clinical signs you're looking for would be hypotension, usually with a narrow pulse pressure, jugular venous distension, and diminished heart sounds. You're also likely going to see some tachycardia, and you may see something called pulsus paradoxus. Pulsus paradoxus is when the systolic blood pressure decreases by more than 10 millimeters of mercury during inspiration. So normally during inspiration, you're going to have a drop in your intrathoracic pressure, which increases venous return to the right heart, and your right ventricle will expand. If you have tamponade and you have this effusion around the ventricles, you have kind of fixed elevated pericardial pressures. The RV cannot expand without encroaching into the left ventricle space. So you have a shifting of the ventricular septum. The left ventricle actually gets smaller, and you're going to have a decrease in left ventricle filling and stroke volume, and that's why you see that drop in blood pressure when you take inspiration. If you have a patient with cardiac tamponade, the treatment for that would be an urgent pericardiocentesis, where you actually stick a needle into the pericardial space and drain the fluid that is causing the obstructive shock. So the main treatment for pericarditis is nonsteroidal anti-inflammatories, which are effective for treating the chest pain. You also want to see those inflammatory markers come down. And so usually you can use ibuprofen or naproxen or aspirin is also an effective NSAID, but you need pretty high doses. Colchicine has also been found to reduce the risk of recurrent pericarditis, and so colchicine will be used in addition to NSAIDs, and typically it's given for a 3-month course. Corticosteroids are frequently used for pericarditis, but there's no randomized trial data, and observational studies suggest that they may increase the risk of recurrence. And so typically you're only going to use corticosteroids if patients have failed NSAIDs and colchicine, or they have contraindications to NSAIDs and colchicine, like renal failure. Unfortunately, pericarditis frequently recurs, and so for your first recurrence, you're going to still treat it with NSAIDs and colchicine. You'll just do a longer course. If they have a second recurrence, though, the FDA has approved interleukin-1 blockers to treat those patients. So anakinra is a daily injection that you can use, or rilonacept is a weekly injection. And typically, you're going to treat them for 6 to 12 months to prevent recurrent pericarditis. One of the worst complications of pericarditis is constrictive pericarditis. And so if you have chronic inflammation, it can lead to a thickened, fibrotic, non-compliant pericardium, which will impede diastolic filling of the heart. These patients come in with symptoms of right and left-sided heart failure, and on exam you'll see an elevated JVP, and there's a special sign called the Kussmaul sign when the JVP actually rises with inspiration. They may have pulsus paradoxus, just like cardiac tamponade. And then another thing you might see is this early diastolic heart sound called the pericardial knock. And these patients should be evaluated with echo. Often we'll do cardiac MRI as well, and then a catheterization to actually measure the pressures in each chamber, because typically in constrictive pericarditis, all of the chambers will have the same pressure. This is treated with a surgical pericardiectomy, which is a pretty morbid surgery, but it's really the only treatment for constrictive pericarditis that works. All right, we made it. What a journey that was. So we talked about a lot of different causes of chest pain. Hopefully you feel more confident in your ability now to evaluate patients with chest pain, and thank you for your attention.